I'm going to look at my cheat sheet here. Scott he specializes in transfusion medicine and cell therapy, hence my interest in inviting him. He is vice chair of clinical operations in the University of Nebraska Medical Center, Department of Pathology, Microbiology, and Immunology. He also serves as professor, medical director of the um-lmp biologics production facility, and medical director of the Apheresis services for Nebraska medicine. Dr. Koepsell received his bachelor's in science and chemistry at the University of South Dakota. He received his PhD in microbiology at University of Nebraska Medical Center, as well as his MD. And he completed his residency at Nebraska as well in AP and CP. And then we were lucky to have him come and join us in transfusion medicine as our fellow. When was it, 2011?
Yeah.
Yeah. He wrapped that up, in July or the end of June in 2012. So it is do you have your talk?
Yep, I'll go ahead and share it if that works.
Do you want to pull it up? I know what you're talking about, but I don't have the actual title. So I wanted to see the title before I introduced it. But it's entitled Pathogen-reduced platelets. What is the real cost and benefit? So thank you, Scott.
All right, thank you. And I just wanted to confirm you can see the screen okay and hear me all right?
Yep.
Perfect. Well, thanks for that kind introduction, and thanks for the opportunity to visit with you all today on pathogen-reduced platelets. I have some very fond memories of my time sitting in the Mayo building, especially in the fall, and this time of year in the spring. It was just really nice to be there and miss it a lot. It's hard to believe it's been that many years already. So today we'll be talking about pathogen-reduced platelets and really kind of go over some of the cost and benefit. Just a quick disclosure, none of which should be discussed in this talk at all, but I am on an ad board and get some research funding from Werfen. So our goals is really to talk about how is pathogen reduction achieved in blood products, and specifically we're going to be focusing on platelets today. And we're going to talk about some of the uncertainties involved with seeing how effective that pathogen reduction process is, and highlight some of the in vitro testing and in vivo testing that is used to predict its efficacy in combating transfusion-transmitted diseases. We'll switch gears and talk about the clinical evidence associated with pathogen-reduced platelets in a real-world setting. So how well does it actually reduce transfusion-transmitted diseases when we look at it closely? And then also, because this is a processing of the platelets, adding chemicals and light in some cases to the platelets, does it affect the hemostatic function? And is that something that we can look at in a meaningful way? And hopefully we'll tie this all together with the MyPlate trial that was wrapped up a couple of years ago and published last year. It was a multi-center trial that the University of Minnesota participated in. And so hopefully there's some interest and benefit from hearing about that again here, and really discuss about what are the role of these type of platelets in patient care. So to sort of level set, I know not everybody is in transfusion medicine, so I like to kind of go back to the basics a little bit and describe what pathogen reduction technology is and how we use it to apply it to blood products. So, just like any good talk, I start off with a definition from the glossary there that pathogen reduction is the exposure of blood components to a system designed to reduce the risk of transfusion-transmitted infections. So in other words, it's just a way of treating blood products to hopefully reduce the risk of anything infectious in there surviving. We'll also talk about the processes designed to reduce the risk of any white blood cells that survive or live in those blood products from being infused into a susceptible host, reproducing and causing that fatal complication, transfusion-associated graft versus host disease. So currently there are three major commercial systems out there. The one that's licensed in the United States is called the Intercept system, and that's from the company called Cirrus. And that is a process where they take the chemical psoralen, inject it into the blood product, and then expose the blood product to ultraviolet light. There's another product out there that's available in Europe called Mirasol, and that's from Terumo. And similar concept, but instead of using a psoralen chemical, it uses riboflavin, so vitamin B, and ultraviolet light. And then there's another product out there that uses the C wavelengths of ultraviolet light alone in high doses to inactivate whatever is within those blood products. There's other versions of this as well, but those are the three main ones that are out there. Because the MyPlate trial involved Mirasol, I'm just highlighting that one as an example. But essentially, it's taking riboflavin, which is sort of a planar molecule, adding it to the pathogen, to the platelets that we're interested in pathogen reducing, and shining ultraviolet light across that product. And what that does is the ultraviolet light interacts with the riboflavin, and the riboflavin, when it interacts under ultraviolet conditions with the nucleic acids of viruses, bacteria, parasites, and white blood cells, forms covalent bonds and allows that damage to occur. So basically, you can think of pathogen reduction technologies as a way to beat up the DNA and RNA in the blood products. And hopefully that gets rid of any infectious potential or reproductive potential of white blood cells and pathogens. So, ideally, any pathogen reduction technology would have some ideal characteristics. And one of those ideal characteristics would be complete inactivation of every known and unknown bacteria, virus, and fungi. And when we talk about pathogen reduction technologies, you might also hear the word pathogen inactivation. I really don't like to use inactivation as a term to describe these platelets. I use pathogen reduction because, as we'll point out, none of these technologies are quite perfect, and it's impossible to completely inactivate every known or unknown bacteria, virus, and white blood cell out there. So you'll hear me call them PR platelets or pathogen-reduced platelets throughout the talk here. But an ideal PR product would have complete inactivation of these potentially transfusion-transmitted diseases. And you can imagine that this has a lot of attractive qualities because new and emerging threats are happening all the time. In 2014, there's a big Ebola scare. Recently, of course, with SARS-CoV-2, COVID, had that virus had significant viremia, especially in asymptomatic donors, that could have been very scary given the magnitude out there. And so having a process that could potentially cleanse the blood or inactivate the blood of any of these viruses would be very attractive. Recently, Mpox was a concern for transfusion transmission. But I'll point back a few years to Zika virus. That was really one that highlighted the importance of pathogen reduction potential, because if you think about Zika virus, it was common in the Caribbean for a while. Many of us travel to the Caribbean in the wintertime to get some sun, and we come back with Zika infection that is completely asymptomatic. So that means you can go donate blood and have no fever and pass all the screening tests and potentially put some Zika virus into a blood product that could be transfusion transmitted. So these pathogen reduction technologies have this promise of, potentially safeguarding the blood supply from bacteria, viruses, and fungi, parasites, et cetera. And ideally, any pathogen reduction process wouldn't have any effect on the function of the blood product. So if it's a red blood cell, it wouldn't affect the oxygen carrying capacity. If it's a platelet, it wouldn't affect the hemostatic potential of those platelets. So in theory, there could be a lot of economic benefit of pathogen reduction as well, in the sense that if it worked well enough, we could drop infectious disease testing of blood products from donors. And that would save a lot of money when we talk about a blood product. I'm not exactly sure what the University of Minnesota pays for a blood product, but it's several hundreds of dollars probably per unit. And a lot of that cost goes toward infectious disease testing. So if you had a technology that you're going to apply to that blood supply, you could potentially get rid of those tests and save a lot of money. The other thing economically, or from a supply standpoint, that pathogen reduction has been discussed as potentially having a benefit is that we could pay donors for platelet donations. The Midwest is pretty good at producing a lot of platelet donors, and so we typically don't have the supply chain shortages that the big centers on the East and West Coast have. But for many centers, daily shortages of platelets is a big issue. And so if you could cleanse the platelets of any known infectious problems with pathogen reduction technology, you could actually pay donors and potentially increase the supply of platelets so that we don't have any shortages. And I just point out a study because I think it's interesting. In 2021, there was a study that looked at a place that had blood donations, and that's in the red, the rate of blood donations. And then at the same time, a pay for plasma donation center went, sort of next door to that blood center. So voluntary donations are in the red and paid donations are in the green. And they showed that as people were paid in St. Louis for their plasma products, it did not affect the rate of blood donation, at least in that community. So there is a potential out there. It's interesting to talk about. So when we talk about pathogen reduction and efficacy, I think it's helpful to march through a few examples because if you think about it, we know that there are, millions and millions of different bacteria out there, and we can't predict or test every single strain of bacteria through these pathogen reduction processes like we think about with a good validation step in any laboratory test. And so typically we rely on in vitro tests to sort of assume or look at efficacy of these pathogen reduction technologies. And so if we focus on bacteria, you can ask the question, well, how do I know if a pathogen reduction technology works or not? And if it does work, how well does it work? And so typically how these studies work is you get a pool of platelets or an apheresis product, and you spike it with a lab-grown bacteria at a certain level. So 100 colony-forming units, for example, is inoculated into that platelet. So you know that there's bacteria in there, and you know what strain it is. You split that product, and then you have your control products, which will probably grow a certain amount of that bacteria, and you can titer that and then quantitate. And typically what happens is you spike a certain low level into the original product, and the untreated, unpathogen-reduced platelet will grow more bacteria, and you can quantitate that. Well, you can store those platelets and then perform pathogen reduction and do the same thing. And in an ideal situation, you would have maybe sterile product after the pathogen reduction process, or maybe it'll grow bacteria, but at a much, much lower rate compared to the untreated product. And so you can do some math and look at the log of the bacteria count that went in, divided by the post-treatment bacterial count, and you'll often hear this term called log reduction in bacteria that is reported commonly as a surrogate marker for how well this works in patients. Of course, you can imagine that this is very highly artificial, and when we think about a normal transfusion transmission of bacteria, we have typically healthy donors who maybe have a skin plug or a skin contamination or a hair follicle that gets put into the bacteria, or gets put into the the platelet product, and starts growing at a very low level, and we transfuse that unbeknownst to us. So it doesn't really exactly match up with how transfusion transmitted bacterial infections occur, but it is one way to look at it. And when we use this sort of study, this in vitro study, to look at the different technologies, and I just put up some example bacteria here, so a gram-negative and a gram-positive, you can see that in the Mirasol technology, the fold reduction for E. coli is pretty good. For Staph aureus, it's pretty good as well, but not as good as for the gram-negative bacteria. You compare that with Intercept, you can see that Intercept technology has, in this in vitro system, much more reduction of the ability of bacteria to grow under these conditions compared to Mirasol. 5 or 6-fold log reduction of bacteria for that. And then you can see the Theraflex, which is just ultraviolet light, and the C wavelengths alone can have even better efficacy in some ways from these assays. So when you look at these publications, and there's a lot of publications out there for each of these pathogen reduction technologies that the company puts out, where they might do 20 strains of bacteria and show this impressive log fold reduction. And overall, it does look very impressive. But again, I just want to stress that I don't think there's really clear clinical correlations of how does this translate to what our patients actually experience in real world situations. And you can ask the question, is there a better measure out there? Well, it turns out people have thought, well, okay, maybe there's better ways to do this. And another way that these technologies are assessed is asking the question, well, how much bacteria can I put in, treat it with the pathogen reduction technology, and then still get a sterile culture out at the other end? So in other words, how much bacteria can we dump in and neutralize with these technologies? And you can see that across a wide range of bacteria, we have Intercept on the left, Mirasol on the right. Intercept is probably superior technology in terms of inactivating these bacteria compared to Mirasol. And so again, highly artificial, lab-grown strains of bacteria, not typically present on the skin of blood donors, but that's what we have. So when we talk about viruses, it gets more complex because it's really hard to grow viruses, and there's no standard ways of doing colony forming units and growing them out at the other end in a culture. So we have to rely on even further artificial ways of looking at this. But again, just to highlight, viruses are probably one of the bigger threats out there to the blood supply in terms of unknowns. And again, I highlighted this a little bit before, but mpox has been published. When that came out, they showed that Mirasol technology reduces mpox infectivity in an in vitro assay. Of course, SARS-CoV-2 was a big scare, and we didn't really know how viremic patients could be or donors could be. But this technology was shown in an in vitro system to be inactivated by Intercept. Not necessarily related to platelets, but I just wanted to highlight that back in 2014, we used convalescent plasma, much like we used convalescent plasma with COVID-19. We used convalescent plasma to treat patients with active Ebola infection. And we did a study where we showed that the protective antibodies weren't really changed by pathogen reduction technology, which kind of makes sense because those are proteins and this technology really targets nucleic acids. But to highlight how artificial the virus surrogate methods of testing or proving efficacy for pathogen reduction technologies are, I'm just highlighting the mpox assay that was out there. And essentially, just like all sort of viral assays, what you do is you plate a bunch of cells and you add different titers of virus to that cell culture and you look for cell killing. And you find a level of virus that kills roughly half the cells, and you call that the TD50 dose. And basically what happens is you can show that, okay, I inject a certain amount of virus into the platelets and I get this amount of killing with that level of virus. And then I do the treatment, the pathogen reduction treatment, pull that out, and then I culture that with the cells and I show less killing of the cells. And that shows that the virus was inactivated because it's not killing the cell culture as much. But of course, we know that whether it's bacteria or viruses, there's a lot of variables that go into transfusion transmission of diseases. Host susceptibility, so the same number of virions might not cause disease in everybody, but in immunocompromised patients, just a few virions might be infective. In immunocompetent host, maybe not. The infectious dose can vary quite a bit, and some strains and some versions of different viruses have different infectious doses. Many of the viruses that we worry about have issues being cultured or have very difficult times being cultured, and these plaque neutralization assays can be very finicky and tough to deal with. And so overall, all these pathogen reduction technologies have lots of data out there showing that in whatever in vitro assay that these technologies seem to be beneficial for quite a few of the viruses. And again, just to highlight that when we look at the different viruses and this log tissue culture infectious dose reduction, you can see some pretty impressive log reduction with this technology, especially for some of the sort of wimpy viruses like HIV-1, which of course is a big blood scare. A lot of patients to this day are very worried about getting HIV in blood. We can see that both Mirasol and Intercept have very significant log fold reductions in HIV. So that's probably one virus that can be very well inactivated by this technology. But for those folks who study viruses, this is never any surprise to them. Non-envelope viruses are very resilient to being damaged. A lot of these can be single-stranded. A lot of them just don't have that ability to take up those planar molecules and interact with ultraviolet light in a way that is meaningful for pathogen reduction. So non-envelope viruses are not inactivated well at all by any pathogen reduction technology. And so no matter what we do with the current use of ultraviolet light and plus or minus the chemicals, things like hepatitis A, parvovirus B19, and hepatitis E are not inactivated very well at all by these. And so theoretically, transfusion transmission of these diseases probably would not be changed by using the current level of pathogen reduction technology. So I just gave a couple examples of bacteria, viruses. Same question comes up with how do we reduce the risk of transfusion-associated graft versus host disease? And again, this is very difficult to study because in the real world, what happens is a susceptible host, whether it's through HLA interactions or immunocompromised state, gets some white cells from a donor in a blood product that are able to replicate and recognize the recipient as foreign, and ultimately they start attacking the host, and usually it's fatal. Well, how do you prove that pathogen reduction completely prevents that? In fact, that's a tough question to answer, because when we look back at irradiation of blood products, which is what we all accept as a preventative measure, there really has been no randomized controlled trial studying irradiated blood products versus non-irradiated blood products in the prevention of graft versus host disease. It was a measure that was implemented decades ago, where we just assume it works, but we've never really tested it and looked at it in detail on a clinical level. There are a lot of in vitro assays where you can take lymphocytes and stimulate them with mitogen or mitomycin C and show that they proliferate, and then you pathogen reduce them with whatever technology. This one happens to be Mirasol, and show that they don't proliferate in the test tube with mitogens like mitomycin C. And so that's a surrogate measure that white cells are inactivated. They have also done this graft versus host studies in mice, where they take a certain mouse model that gets graft versus host disease and show that if you take white cells and put them through the pathogen reduction process, and this is at various concentrations of that psoralen used in the Cirrus product, that pretty quickly you inactivate them to the point where in this in vivo model with mice that there is no replication of those white blood cells, and theoretically there would be no graft versus host disease. But again, these are surrogate markers that we've never really shown or tested mean anything in people. We take it as an assumption. So even though we've implemented this pathogen reduction technology in a lot of countries, and certainly here in the United States as well, it is not foolproof. And there are certainly other measures for preventing bacteria contamination in platelets. And the FDA a few years ago actually went as far to mandate that we all have to follow basically one of three processes. All of us have to either use pathogen reduction platelets, or we have to do a large volume delayed culture of every platelet that we use, or we have to do a sort of almost a point of care test, where when we issue platelets, we pull off a sample of those platelets and test them for any bacteria presence using sort of antibodies against common cell antigens and bacteria. So all of us, including the University of Minnesota, are doing one of those three things as mandated by the FDA a few years ago. And this is at very, very great cost to all of us. So I just want to point out that there are case reports out there, and this is one case report that was reported in 2020, that a male with ALL got a unit of pathogen-reduced platelets and developed a septic transfusion reaction. So we thought, wow, we went through all this cost and effort to implement these technologies to prevent this bacteria transfusion transmitted disease process, but this still occurred. How could this be? Well, the patient, his blood and his peripheral line grew Acinetobacter. And when they rinsed the implicated unit that was transfused into him, and again, this was a pathogen-reduced unit using the Cirrus technology, it grew that Acinetobacter complex as well, in addition to the Staphylococcus species as well. They subcultured these two bacteria and put them through the intercept process in vitro and show that they were in fact susceptible to the pathogen reduction technology. So how in the world did this platelet undergo pathogen reduction technology and yet transmit bacteria to the recipient? Well, the intercept process might have failed, but the most likely source that they came up with was actually the bag that the platelets got put into after the pathogen reduction process was contaminated. So this is one of the things that highlights that even though we do this pathogen reduction technology, we can still have bacteria that are infused into our patients. And so it's not a foolproof process as well. So to summarize this first third of the talk or so, I just want to highlight that bacteria, viruses, I didn't show you the parasite data, but it's out there as well. And leukocytes all have nucleic acid that can be damaged by these pathogen reduction technology systems. Depending on the system, there's various levels of inactivation by each technology. In vitro, the Cirrus technology seems to be superior to Mirasol. But again, who knows what level of inactivation you need to be clinically effective. And no matter the system, there are some weaknesses, including those non-envelope viruses, hepatitis E, A, and parvovirus that I talked about. So the question I want to shift to is, what does real-world data tell us about the implementation of these products, and how does it actually reduce the risk in platelets? Unfortunately, this has been done on a large scale in a way that we can study pretty well. And the example that I want to highlight was one that was published last year with the experience over in France. So France in 2017 completely switched their platelet supply to pathogen-reduced platelets, and they use the Intercept technology. So that's that Sorolin technology. And at that time, they were experiencing about 3 cases of bacterially transmitted transfusion disease per year. And you can see those number of cases in the orange bar on the left here by year. And 2 of the cases were fatal, so 1 in 2013 and 1 in 2015. And then in 2017, they implemented and switched over, and you can see that the rate of these bacteria, recognized bacteria transfusion-transmitted diseases dropped pretty dramatically. In many years, there was no recognized cases at all, and there certainly was no fatalities after they switched over that. So a couple things to highlight here. Number one, transfusion-transmitted bacterial infections are incredibly rare, just a handful per year. But clearly this technology or implementation of this technology dropped the rate here. So I see somebody raised a hand.
Yeah, that's me, Scott. Claudia.
Oh, hi.
How you doing?
Good morning.
Good morning. Thanks for a great talk so far. This is not well known yet, but France recently had a fatal septic transfusion reaction from a platelet that was pathogen-reduced. It was Staphylococcus aureolithecus found in the bag. So Cirrus is aware. They're doing a full investigation, but it's, they're very few and far between, but they're happening. And it'll be interesting figuring out why. Just wanted to bring that up while you were talking about France.
Yeah, no, I certainly appreciate that. Again, highlights that case report I just mentioned that these are not foolproof technologies. But clearly they do have, on a very rare event, a significant amount of reduction in the rate of these bacterial infections. When they do the math, they said, their rate was 1 in 92,687 transfusions resulted in a transfusion-transmitted bacterial infection, and that dropped to 1 in 1.6 million, and that seemed to be significant. These 2 cases in 2017 and 1 in 2021, I have listed the bacteria that were there, so Bacillus cereus, and they questioned could that be a spore, Citrobacter, Salmonella, and now it sounds like a new sort of staph species. So certainly not the usual skin flora that we think of. And typically the bacteria that get through are quite unusual in some ways. So there you go. There's definitely a reduction in the rate of this very rare thing. They also pointed out that in France that transfusion-transmitted hepatitis E occurred at a similar rate both before and after implementation of Intercept, and that ranged from 1 to 5 cases per year. And that makes a lot of sense because in vitro studies certainly show that non-envelope virus was not well inactivated. And so hepatitis E is a well-documented sort of transfusion-transmitted event in Europe. Might be here in the US too, we just don't really test for it. They also point out that hepatitis C, B, and HTLV infections were so low before the implementation of Intercept, and as HIV as well, that there's really no way to statistically show that before or after that Intercept technology had any difference whatsoever. So this next slide here is more just speculation or sort of drawing conclusions myself. I have no idea what France is paying for Intercept technology, and the cost for using this technology is quite variable depending on where you're at. But there are some numbers in the literature, and I just wanted to use published data that's out there. So one study showed that the cost for Intercept is probably $136 or so extra per unit in the United States. And the cost of doing that other bacteria reduction strategy, large volume delayed sampling, was about $83. So again, we have to do one of these, or that sort of point of care test before issuing it, but we have to do one of these. So the difference between culturing your platelets using this expanded technique versus using pathogen-reduced platelets is about $53 more per unit. And in France, in those study periods, they transfused 329,000 platelets per year. So if you multiply that by $50 conservatively, they paid, close to $16.5 million a year for that added safety of a reduced number of bacterial infections. And if you do the math, that's about $1.5 million per case saved. So I'm not in public policy or anything like that, but it certainly is a huge cost to reduce a very rare event. Now, not diminishing it, because if that was your loved one who got that bacterial infection that was especially fatal, that means a lot, and that can be very significant. But I'm just pointing out that we're putting in a lot of resources into this technology, and it does have efficacy with bacteria, and it does make a difference, but it can be quite expensive. So one thing that France did not point out, or they pointed out but they didn't really discuss in their paper, is this increased number of platelets transfused per year. And this is not entirely clear to interpret because we don't know what the denominator is. We don't know how many patient visits there were between the different years. But we do know that before Intercept, they were transfusing about 301,000 platelets a year, and after Intercept, about 329,000 platelets per year. So there are clearly a lot more platelets transfused after implementation of this technology. And again, they didn't really address that. But we do know that in all the studies of pathogen reduction technology, that these platelets, probably because of the process of getting light shown on them, manipulation, and so forth, require more platelet transfusions. So when we use pathogen reduction platelets in a center, we know that we use more platelets. We know that when we do the studies, there's lower corrected count increments, and we know that there's shorter intervals in between transfusions. This has been shown in every single study with pathogen reduction technology. So it's not a big leap to think, well, they don't increase the platelet count as well as conventional platelets. That's probably why they're using more platelets there, but I don't know. And the question really is, does this translate to more bleeding risk? So when we look at the reviews of all the pathogen reduction technologies that are out there, one that was published in 2017 looked at 12 different trials, and they had statements that said things like, there is no evidence of a difference between pathogen-reduced platelets and standard platelets in the incidence of clinically significant bleeding, and there's probably no difference in the risk of severe bleeding. And certainly the FDA has used a lot of these studies and claims to approve serous platelets here in the United States, and the EU as well has used these studies to approve both Intercept and Miracell platelets in the European Union. So I just want to, again, just like the in vitro stuff is very tough to correlate to what does it actually mean for our patients, I want to point out that these studies looking at clinical efficacy in patients receiving pathogen-reduced platelets also suffer from a lot of issues. And assessing bleeding in these studies is a very difficult thing. I think the University of Minnesota has a very long history of doing these studies and actually doing it very well, but I also understand that there's been a dedicated nurse or two that has done a majority of the bleeding studies in a very consistent way. So how can we look at the risk of bleeding when you get pathogen-reduced platelets? Well, in these studies, we use corrected count increments a lot, and we know that those are not as good when you use a pathogen-reduced product. But also we rely on a patient, a bleeding assessor, typically a nurse, going to the patient and doing a bleeding assessment. And so training those assessors, doing a bleeding assessment tool. And again, depending on who's doing the bleeding assessment and what tool you're using, there's very low reproducibility among bleeding assessments. And that's been well published and known across these studies, and it's a major limitation to address these. So typically what happens is we grade bleeding on this WHO scale. And so grade 1 bleeding are things like epistaxis, petechiae, purpura that are less than 1 inch. And grade 2 are basically the same things, but a little bit worse. You know, bloody noses that last a little bit longer, purpura that are bigger than 1 inch, and so forth. Grade 3 bleeding are things that actually require a blood transfusion. So you've bled enough where you need a transfusion. And you might be hemodynamically unstable. And then grade 4 typically is hemorrhagic shock or fatal bleedings. There are very few rates of grade 3 and grade 4 bleeding in our patients due to thrombocytopenia or platelets not working anyway. And so it's, again, a very rare event. And so when these trials looking at pathogen-reduced platelets are designed, almost always they include grade 2, 3, and 4 bleeding to get a number of events high enough to do statistical analysis. If we just relied on grade 3 and 4, we'd have to enroll thousands and thousands of patients, would be very costly to get meaningful data. The issue, though, is that when we talk to our hematology and oncology colleagues, grade 1 and grade 2 bleeding often are annoying, but are not considered clinically significant. They know that a certain number of their patients who have hypoproliferative thrombocytopenia will develop some of these problems, and that's just the way it is. They, put some tissues on their nose and it goes away after a while, for example, but it doesn't require a blood transfusion. So a review was published, I guess about 4 or 5 years ago now, that kind of collated all the different randomized controlled trials looking at the serous product, the amotosalen product, so Urosprite, Sprint, Iptas, Epipap, and Sprint probably, I think, was done partially at the University of Minnesota as well. And then the riboflavin trials, Miracle, Prepares, and Iptas. Iptas was an Italian study that compared both serous and compared both the serous product and the Mirasol product as well, but was stopped short because of funding issues and had low enrollment. And when we looked at the endpoint, and these endpoints again were used for approval by regulatory bodies, you see things like corrected count increments and the proportion of patients who develop grade 2 or higher bleeding. So what percent of patients in the pathogen reduction group compared to the control group develop grade 2 or higher bleeding? And so this was the primary endpoint that was used across these studies and was used to make those claims that there's probably no clinically significant difference between pathogen reduction technology platelets in clinical care versus conventional platelets. So fast forward to the MyPlate trial that we're going to spend the next few slides focusing on. And again, this was a trial that was also performed at the University of Minnesota, where we had a multi-center trial where we enrolled prospectively patients who had hypoproliferative thrombocytopenia and a hematologic malignancy, so leukemia, lymphomas, who were undergoing mostly bone marrow transplant, but also potentially chemotherapy consolidation, to receiving either Mirasol platelets or standard of care platelets, and we did a bleeding assessment as per all the other studies. This was unable to be blinded, though, because of this bright yellow appearance of the Mirasol product. And so patients who are on this could look up and see that they're getting a bright yellow product versus a standard of care product. So it was unable to be blinded. Again, they were randomized to get just standard platelets in plasma compared to the Mirasol treated platelets. And one thing that I want to point out here, because this probably was a major flaw in the study, was that irradiation of the platelets in either arm was done at the discretion of the treating physician. And all of us know that typically patients with either a bone marrow transplant regimen or potentially even acute leukemia in some centers get irradiated blood products. So I pointed out that a lot of the endpoints for all the previous studies that were used for regulatory approval included corrected count increments. So how did the platelet count respond after transfusion, or the percent of patients who develop grade 2 or higher bleeding. For this study, though, in the United States, a primary endpoint that involved a number of days with grade 2 or higher bleeding was used instead of the percent of patients with bleeding. That proportion of patients, the percent of patients with WH2 grade 2 or higher bleeding was part of this study, but it was a secondary endpoint and not the primary endpoint. The FDA insisted on this endpoint of number of days with bleeding to be maybe more a sensitive measure of clinical efficacy. And that had been one of the secondary endpoints in the Iptas study as well. So that might have been an impetus for them to want to use this as well. But nonetheless, it was a novel endpoint that had never really been studied in this sort of aggressive fashion across multi-center randomized control fashion. And we also looked at the usual corrected count increments and transfusion episodes and so forth per patient. Overall, we had 11 hospitals, including the U up there, that recruited over 422 subjects for consent. There were 92 screen fails that left us with 330 subjects in the analysis set. Of those, 28 did not receive any transfusions. 5 subjects got the wrong transfusion, so they probably were in the Mirasol group, but there were no Mirasol platelets available and they needed a transfusion, so they got the control platelets and they had to be removed from that. And that left us with 297 subjects in the modified intent to treat group, 145 in the Mirasol, 152 in the control group. The breakdown of patient disease was pretty typical for what most centers see: leukemia, lymphoma, myeloma. And then you can see that the least frequent patient enrolled was somebody undergoing chemotherapy for acute leukemia, typically. We had quite a few patients undergoing autologous bone marrow transplant, and then a little over a third were getting allogeneic transplants. This trial was meant to involve both children and adults, but we enrolled typically mostly adults, and very few children were actually enrolled. And you can see that the age and gender were pretty much the same between the two arms in the study. So what did we end up finding? Well, we had a non-inferiority of 1.6 that we wanted to achieve. So we wanted to get a relative rate of bleeding, days of bleeding that kind of overlap this region of non-inferiority, or even better, be lower than 1.6. But instead what we got was a relative rate of 2.79 with confidence interval that ranged from 1.67 to 4.67. So we were close to our region of non-inferiority, but definitely we're not going to get there if we finished out this trial. And so because of this data, the trial was prematurely ended halfway through. So very disappointing in a way, but not entirely surprising that these platelets were shown with this very sensitive clinical outcome to not be as good. What does that translate to actually when we look at what does it mean for the patient? On average, in the Mirasol group, there was 1.7 days of grade 2 or higher bleeding with a standard deviation of 4 days, compared to the control group where there was about 0.6 days of bleeding grade 2 or higher with a tighter standard deviation. And so the conclusion, from the study officially was that Mirasol did not meet the non-inferiority endpoint. I do want to point out, though, that when we talk about the previous endpoints used in other studies, we had 40% of patients with grade 2 bleeding in the Mirasol arm compared to 30% in the control arm. And there was a trend there, but it certainly wasn't statistically significant. And again, in the grade 3 arm that clinicians typically care about, there's 4% versus 1.3% and not statistically significant. Interestingly, the percent of patients and where they bled in the two arms was odd to me. If we look at the pulmonary group, so these are patients who probably had hemoptysis, there were quite a few more patients who had hemoptysis in the Mirasol group compared to the control group. When we look at epistaxis or skin involvement, very similar rates between the two groups. So that didn't make a lot of sense to me, but that's what we ended up with. When we look at some of the other endpoints here, we can see that the corrected count increment was much lower. The number of patients with low corrected count increments or platelet refractoriness was much higher in the Mirasol group compared to the control group, and that was statistically significant, exactly like we've seen with every pathogen reduction trial before. Yet you don't get as good of a platelet count afterward, and in fact, you need more transfusions per patient, and the days between platelets tends to be lower, although that wasn't significant. We didn't see any difference in red cell transfusions between the two groups. It wasn't significant. So people in the control arm versus the Mirasol arm weren't getting fewer red cell transfusions. So at least on that level, it seemed to be quite equivalent. And when we looked at safety between the two groups, the rate of events that came up were the same. So the conclusion of that trial was basically that these pathogen-reduced platelets with the Mirasol system did not support the claim of non-inferiority using this novel primary endpoint of number of days with grade 2 or higher bleeding for clinical effectiveness. And the subjects getting the Mirasol platelets had very similar secondary endpoints, that, especially when you compare them to previously published studies. And again, very similar proportions of patients who had grade 2 bleeding between the two arms, although there was a trend to higher bleeding in the MIRASOL arm. We saw lower platelet counts after transfusion and more transfusions in the pathogen reduction group, just like everything else, similar safety events. So a lot of issues that came up with this study. One of them was that it was unblinded, and so patients knew that they were getting experimental platelets. And when they got their bleeding assessment after they left the hospital, it was by telephone. And so a coordinator would call and say, are you having any blood tinged sputum? Are you having any bruising? And I don't know for sure, but there's certainly the potential that there was bias, and patients who got experimental platelets might have paid more attention to their sputum secretions or noticed blood flecks more than patients who got the regular platelets who might have just blown it off or not paid much attention. Another limitation of this study is we had a lot of patients undergoing autologous BMT, and as you know, like a lot of experienced centers, there are recommendations out there that you don't actually even transfuse these patients with platelets until they develop bleeding. So this prophylactic use of platelets in this patient population might have skewed the data a little bit. Probably the big thing that was out there, though, was that greater than 95% of the patients in the MIRASOL arm were also irradiated. So you can imagine that getting beat up with a pathogen reduction process followed by irradiation could potentially have had a damaging effect on these platelets. It's very hard to understand this because irradiation alone has very negligible changes in platelet properties when measured in vitro. There are differences between X-ray and gamma radiation, and these have not been directly compared. But certainly from an in vitro standpoint, there's not a huge difference in what we see after irradiation. There are some studies out there that have looked at irradiation plus amotosalen, so the Cirrus product, that seems to show similar damage to platelets that are not terribly significant. And there's also proteomic analysis out there of these MIRASOL platelets that show there are changes, but not terribly significant. But certainly, that is one theory that might have contributed to why these platelets did not perform to this novel endpoint of days of grade 2 or higher bleeding, is that they were kind of doubly beat up. The other alternative, or maybe in addition, is that this endpoint is just more clinically sensitive than the proportion of patients who develop grade 2 or higher bleeding. And maybe that should be the measure by which these technologies are assessed going forward. I just want to highlight that, again, we had 40% of patients who developed grade 2 or higher bleeding in the MyPlate trial who got MIRASOL platelets compared to 30%, not statistically significant. Sprint showed 58% versus 57%, and Prepares showed 54 versus 51%. So overall, lower rates of bleeding in this study compared to historical studies. Maybe the standard of care is getting better. Maybe there's different changes out there in our patient population, maybe less sick. But at any rate, if we just had used this as an endpoint or the secondary endpoint as a primary endpoint, this study probably would have been a success, at least compared to those previous studies. And I mean, I think it begs the question, what if we use this novel endpoint of days of grade 2 or higher bleeding with the other two pathogen reduction technologies out there? Would we see a similar non-inferiority sort of finding that we found in this study as well? Not going to go into depth on this, but I just want to point out that there are a lot of other biology considerations other than platelet count and days of grade 2 or higher bleeding. There are models out there that look at the way that platelets affect endothelial tight junctions and permeability. And in these models, it shows that pathogen reduction compared to non-pathogen reduction changes the endothelial permeability in a way that's not favorable. And that can be noticed in these assays. There's probably a lot of things other than platelet count that affect hemostatic ability of these platelets in these patients. And there's going to be more known there. So when we get back to the cost benefit, I hope I pointed out that there are known costs. These typically are quite expensive, and we know that they result in more transfusions and lower corrected count increments. We've shown in a real-world setting in France, especially, that there are fewer transfusion-transmitted bacterial infections, but for virus standpoint and anything else, I don't think there has been a real good reduction shown yet. And I want to point out based off the study I showed you with my plate and all the other previous studies, is that the hemostatic property equivalence to conventional platelets is probably still not typically known. All of these studies have been done in patients with hematologic malignancy typically, and they have not been studied in patients undergoing trauma and surgery. Although now, in France and in centers that have adopted this in the US, these are used routinely in these patients. And my guess is they're not as good as conventional platelets in these patients. Another unknown is that in vitro parameters, whether it's with bacterial inactivation, virus inactivation, or hemostasis, do not reliably predict clinical effectiveness. And it's a big stretch to say this in vitro test shows this, therefore we can expect that in patients. And all of the studies of pathogen reduction platelets have had a huge variety in their clinical endpoints and no standardization in bleeding assessment across the trials. So I think in the future, it'd be important that the societies and the groups come up with some consensus, the FDA and the regulatory groups as well, to come up with some consensus on drawing meaningful conclusions when we look at these technologies. It'd be great if we could validate those in vitro markers, but that's a big stretch and would take a lot of effort. Certainly, one thing that we could do is standardize bleeding assessment across trials and use the same tool and the same approach to get better data across that. I think going forward, any of these trials have to eliminate the confounded problem of irradiating the platelets as well. And then we have to really have a serious conversation about clinical endpoints and the number of patients it takes in these trials. Grade 2 bleeding is probably not the way to go, and rather we probably should look at enrolling enough patients to get enough grade 3 or grade 4 bleeding that is meaningful to look at that. And then that novel endpoint of days of bleeding versus just the proportion of patients bleeding probably should be the standard going forward, since it appears to be either more sensitive and is certainly doable. And I think enrolling patients outside of those in hematologic malignancies, again, just for ease and numbers, is going to be important to look at these. It does worry me that we are using these platelets in patients who probably need a greater degree of hemostasis versus patients who are undergoing chemotherapy and maybe radiotherapy regimens laying in a hospital bed. So to sum it up, I think this technology has potential to make the blood supply safer from transfusion-transmitted infections, particularly bacterial infections, but it is not perfect. They come with significant costs in terms of dollars, as well as more platelets used. The hemostatic function of these platelets probably is close in a lot of ways to conventional platelets, but it's been very tough to compare them in a way that's meaningful. And I pointed out a lot of the shortcomings. And future studies really need to look at patients who are not just having hematologic malignancy treatment, but other areas as well. And whatever study it is, I think we need to insist on standardization across studies to make sure that there is a good consensus around what clinical effectiveness means. And so with that, happy to entertain any questions. I just want to point out all the people it took just to get that MyPlate trial going, which enrolled a few hundred patients. So thank you very much for your time.
Thanks, Scott. That was a great talk. Does anyone have a question for Scott? If you do, speak up, because I don't think I'll be able to see if any hands are raised.
Hey, Scott. This is Claudia. Again, very nice talk. And I think you made this clear, but I'd still like to ask it. Do you think there's any reasonable chance that riboflavin technology, Mirasol, can come to the U.S.?
Probably not in its current form. And I don't know for sure what the company is doing, but I believe they're coming up with Mirasol 2.0, hopefully addressing some of these concerns. And certainly when our study came out, I imagine the European Union probably is having a second look at this as well and coming up with a lot of the same issues. Is there a role for it? I think it'd be nice to have competitors and the ability to evaluate more than one. I think it's probably nuanced too that these platelets, for example, if I were looking at my immunocompromised patients, those undergoing transplant, bone marrow transplant, maybe these are the right patients or platelets for them because, they don't need that hemostatic potential to be that great. They're immunocompromised and bacterial infections can be very, very serious. I'm not sure they're the right things for trauma patients, but I would hope that we had more than just one in the United States at some point.
You probably know that that Aaron Tobin was testing Mirasol in Uganda with whole blood platelets.
Yes.
And luckily, he finished enrollment like a day before all grant funding disappeared at Johns Hopkins, or a lot of grant funding disappeared. So,
yeah, his was red cells though, right?
is that a red cell?
Yeah, he did. He
Yeah,
did red cells.
You're right. I'm crossing studies. Never mind.
Yep. No, but you're absolutely right. I just pointed out platelets this time. This technology is also being used for red cells, which block ultraviolet light and have other issues. But certainly in Africa, where there is greater prevalence of transfusion-transmitted disease and less access to testing of donors, I think this makes a lot of sense. And certainly incremental decreases in hemostasis, if it were platelets or whatever, certainly would outweigh the risk of the huge increase in transfusion-transmitted diseases. And so depending on the setting, certainly this has a lot of potential.
Bane, looks like.
Yeah, I have a question. Thanks for the great talk, Scott. I'm curious, since FDA had input into what the primary outcome should be, given that the MyPlate trial didn't meet the, non-inferiority, does that mean there's some grumblings from FDA about whether they should, scale back on, PRT kind of across the states, or has this changed their thinking at all with regard to this?
Well, they've already approved Cirrus in 14 or 15?
Yeah.
I know that that company will not. They'll be very strategic at any future trials and have endpoints that they agree with. I think once it's licensed, I'm not sure anything is going to be pulled unless there's data to support that. But certainly, I think this trial highlights that we need to use all the same measuring stick when approving these. It was probably, I have no stake in Terumo, but it probably felt a little unfair to them to be judged by a different measure.
Mm-hmm. Makes sense. Thank you.
Nicole?
Hi, it's Nicole. I had two questions, and I apologize. I did get paged out in the middle of this, so hopefully you didn't answer this question. My first was on the age of the platelets, and if you looked at that variable, whether it had any influence, and whether that might influence like just having this platelet available in a remote area if it had like a long shelf life. The second thing is I just wanted to comment on the use of these platelets. Right now, pathogen-reduced treated platelets are being used in cold platelets by sites under our variants. So the addition of one more factor, I just want you to weigh in on that side as well.
Yeah, so we did look at the age, and there was no real difference between these in the MyPlate study, but we were using the 5-day cutoff. Certainly, I think, especially in our smaller hospitals that we support, having a 7-day process with these pathogen reduction technologies adds a benefit that I didn't talk about here. And in those settings, maybe it's worth having one on the shelf and access to that versus a little bit less hemostatic potential. And then, yeah, the cold storage is a whole nother variable. I'm probably naive about this, but I think of, the cold part sort of activating them and making them ready to stick to where there's areas of damage. I have no idea, and I'm not aware of any studies that have looked at what cold plus pathogen reduction or not does to any of the in vitro parameters.
In vitro, it doesn't. The combination is less. It makes them less functional than without the pathogen reduction, but studies are, use a variety of types of assays, and cold platelets sometimes are still better than warm platelets, and the pathogen reduction cold may still be better than a warm platelet in some assays. So it's kind of a mixed bag. But the more you do to a platelet, though, the worse it tends to function. So. But
I think that makes sense to all of us, and it's no surprise. The more you manipulate them, the less they do. So I think we might approve that.
All right. Excellent. I think that brings us to the hour, Scott.
Perfect.
Thanks so much, and we'll see you soon.
I
in New
appreciate it.
Orleans.
Thanks again for the opportunity. Take care.
Yep, take care.